from SCB Medical College, Cuttack, and MCH Urology from Calicut Medical College. And he got laparoscopy training from World Laparoscopy Hospital, Gurugram, and currently working as a urologist at Chaitanya Hospital, Talap, Kannur. Welcome, Dr. Alphonse Jithin, for the speech.
Thank you, sir, for that warm welcome. I thank IMA Kannur for this wonderful occasion. My topic of presentation is renal stone management and what has changed. These are my major headings. I'm going to discuss pathophysiology, types of stones, briefly describe the medical management and surgical. The pathophysiology, types of stones, medical management, and surgical management. Coming to the natural history, it's been estimated that there are asymptomatic renal stones that have been reported in approximately 10% of screened population, and the mean size of 3 millimeter and an average of 2 stones per patient. The peak incidence happens usually between 20 years and 40 years, and it's a male predominant disease. The ratio 3:1, and is more common in mountains, deserts, and tropical areas. The seasonal variation, you all know that it's higher incidence during summer, and it's more common in sedentary occupations. It's been seen that its prevalence has been increasing. The reason is that it's highly linked to obesity, diabetes, and metabolic syndrome. Since these etiologies are increasing, like obesity is increasing, diabetes and metabolic syndrome is increasing nowadays, the prevalence of stones are also increasing. This is the distribution of stone formers in the whole India. It's more common in the northern parts of India, UP, Gujarat, Rajasthan, Madhya Pradesh. 16% will spontaneously pass the stones, and 40% may be requiring surgical intervention, and 45% will show increase in size of the growth. 68% will present as UTI, and 51% of stones people will present with pain. It's been seen that once a stone former, there is a 50% risk of recurrence within the next 5 years. Coming to the types of stones, they are broadly divided into calcium-containing stones and non-calcium-containing stones. Among the calcium-containing stones, the most common is calcium oxalate, accounts for 60%, and hydroxyapatite, brushite. The non-calcium, the uric acid stone, Schroeder stone, cystine stone. So we need to remember 2 types of stones. The most common stone you enter in your clinical practice is calcium oxalate stones. The uric acid is only very less common, it's only 7%. Actually, Schroeder stones they are infection stones. It happens only in the presence of infection. Cystine stones happens, it's a metabolic error, it's very rare. It happens in cystic urea patients. This triangular silica or drug stones, stones, very less common. This is for how stones are formed. First, the presence of calcium and oxalate in the urine, increasing concentration causes saturation in the urine, and in the presence of these promoters, and in the absence of inhibitors. So citrates, potassium, and magnesium are inhibitors. They inhibit the formation of stones in the urine, in the saturated urine. So in the absence of these inhibitors, that is especially citrates, and the presence of high concentration of calcium, oxalate, and uric acid, there will be crystal nucleation initially, followed by its growth, and followingly it will aggregate. These crystals will aggregate around this nucleus. So nucleus acts as a nidus, and they will form a stone. So these are the major steps in the formation of stones. Sites of involvement, it can involve in kidney, especially renal calyces, renal pelvis, ureter, bladder, and urethra. This is the renal calculus. This stone can be symptomatic or non-symptomatic. It's obstructive or non-obstructive. These are small stones are non-obstructive. They usually won't cause any symptoms. This stone can cause symptoms. This stone I am pointing using razor. It can obstruct the whole collecting system and produce obstruction and produce stretching of this renal capsule. This stretching of renal capsule will produce pain. This is stand-on calculus. This is a type of calculus that's formed in the pelvis and its bones are extending into the calyces. These are the calyces. So the form resembles a stag horn. This is a left side urinary calculus causing hydronephrosis and discharge of the kidney. This is a bladder calculus inside the urinary bladder. It's otherwise called vesical calculus. And sometimes these stones can get impacted in the posterior urethra. In this figure, you can see a large impacted calculus in the posterior urethra. Posterior urethra means the prostate. And the clinical features, as we all know, it can be depends upon the location of stone burden. It can be asymptomatic. It can present as dull flank pain. Usually kidney stones that can present as dull flank pain. And when it goes into the urethra, it can produce ureteric colic, especially usually they will produce as GI symptoms, gastric symptoms, because the nerve supply is same for the gut and the urethra and the kidney. So lower urinary tract symptoms, if the stone is in the bladder or the urethra, they can present as lower urinary tract symptoms resembling urinary tract infection like dysuria, urgency, frequency, nocturia, etc. And if the stone usually can associate with infection also. So these patients will present as with fever with chills and rigors. And stone can produce hematuria and also lithuria. Lithuria means the passage of stones inside the in the urine. And renal failure. Coming to the investigations, these are the investigation, uromicroscopy, X-ray, UHCT. But the gold standard for diagnosing acute flank pain is the non-contrast CT. In urine, you should look for the pH. Usually, it's acidic pH, that is pH less than 7 stones forms. But if the pH is more than 7.5, we should always think about infection. So, if the pH is more than 7.5 in the presence of a stone, you should think that it's a dangerous stone. That's infected stones. And uric acid stones is formed at very low pH, less than 5.5. And you can see RBC and pus cells in urine in the presence of stones. It can be seen in the presence of UTA also. So it's not on specific. You can see sediments in crystalluria. The sediments for crystalluria, how a microbiologist identify this by the shape of the stones. So calcium oxalate monohydrate will be hourglass. Uric acid stones will be amorphous shards like that. So these are the crystals in microscope. So the presence of crystals in urine doesn't mean that the patient has stones. This means that if the crystals are found, we can reassure the patient that the crystals are, he should control his dietary habits or he should drink more water. So he may become a strong former later in life. Coming to the X-ray KV, typically calcium containing stones will be radiopaque. So calcium oxalate will be radiopaque. And sugar stones also are radiopaque. But uric acid stones are radiolucent. But it has got a less sensitivity. X-ray KV has got less sensitivity and specificity. It's only used for comparison during follow-up. So during follow-up, we cannot make the patient do CT again because of high radiation. So in this case, we can take X-ray KUV in case of radiopaque stone follow-up. This is X-ray showing to renal calculus and a vesical huge vesical calculus. This is an X-ray showing ureteric calculus. I think you can appreciate the showing here. this psoas shadow, this is the psoas shadow. This ureter will be lying medial to the psoas shadow and parallel to this vertebral, paravertebral and medial to the psoas shadow. It's a huge, very large ureter calculus. Ultrasound, the simplest, cheapest, non-invasive, which will give an idea of hydronephrosis, size of kidney, renal echoes, cortical differentiation. It can identify renal upper and lower ureteric calculus, but mid-ureter is obscured by bowel veins. So any calculus in the mid-ureter is very difficult to find by ultrasound. The sensitivity is very low for ultrasound, is only 45%, but specificity is okay. This is the ultrasonic image of a renal stone characterized by a hyperechoic, that is white in color, with a posterior acoustic shadow. So hyperechoic density with a posterior acoustic shadow. This is the shadow. Is suggestive of renal calculus. And so in these instances, when sensitivity is low, we'll go for CT. We have to do CT. So CT. It is we can diagnose all other abnormalities also, but it can show all stones. Even radiolucent stones can be seen in the CT KUV. Even uric acid stones can be seen in the CT KUV, but except in the inversions, that is drug stones. That is, since incidence is less than 1%, so no issue. And in CT, they will show some Hounsfield units. So by seeing the Hounsfield units, we can guess what is the stone, what can be the stone. So if the high Hounsfield unit, around 1,000 Hounsfield unit, most probably it will be a calcium containing stones like calcium oxide or calcium phosphate. So we stones 330 to 900, and uric acid is having the lowest Hounsfield unit. So if you see a CT, you can predict the composition of stones by seeing the Hounsfield units. What are functional studies? So in plain CT, we'll get an idea of what is stone and where it is located. But we need to know the calyx anatomy if we are planning for any surgery. Calyxes. So we have to give some IV contrast. So IV contrast will be taken up by the kidneys. They will excrete the kidney, the dye into the collecting system, and it will go from the collecting system into the ureter and to the bladder. So this contrast handling by the kidneys, by seeing this contrast handling, we can assume the kidney is functioning, and will give an idea of calyx anatomy. So if intervention is planned, only we have to go for CCT. But if it is small, we a stone, we are not planning for any intervention, CT is not usually indicated. This is a plain CT showing a renal calculus, left renal calculus in the inferior calyx. This is another plain CT. Here we can appreciate there is a hydronephrosis left side, and there is a thinning of the parenchyma of left kidney. And the cause of this hydronephrosis will be traced down. We can see a ureteric calculus in the left side, upper ureteric calculus, obstructing the ureter and causing the hydronephrosis. This is a right vesico-ureteral junction calculus. That is the junction of ureter with the bladder. So it is a narrow point in the ureter. So these are all sites of ureteric impaction. Coming, if a patient, all patients will come to a in our OPD with a severe pain. First before all everything we had, if you are suspecting a ureteric colic, the first part painkiller will you give. So in this, the best effective drug is NSAIDs, because this decreases the pressure inside the. Actually, this pressure inside the kidney is decreased by NSAIDs. How? They will decrease glomerular filtration rate. So there will be decreased pressure in the tubular pressure. So decrease in stretch of the renal capsule and so less pain. But if NSAIDs are contraindicated in some cases, like deranged RFT, then only we can give opioids like tramadol 14 and it is seen that addition of antispasmodic like cyclopam to NSAID does not result in pain control. And these NSAIDs are contraindicated in patients with congestive heart failure, ischemic heart disease, peripheral occlusive vascular disease, and renal failure. This figure explains what all you can give during this acute episodes. We can give us painkiller like NSAIDs, and this ureteric muscle, this muscle contains alpha receptors. So you can give an alpha receptor blocker. So it will dilate the this ureter. So these more stones can be passed very easily. So we can give a painkiller, we can give an alpha blocker, and we should ask the patient to drink more water so that water will come from above and flush this stone out. This lies the basis of medical expression therapy. Coming to the metabolic. Coming to the metabolic evaluation of stones. So when this first episode of stones happens, you can manage all this. Then which patient you will need, you have to see for any underlying metabolic pathologies. These are the indications for metabolic stone evaluation. That is, first time stone formers, no need for any metabolic stone evaluation. But if there are the recurrent stone formers, we have to do some metabolic evaluation. That strong family history, if it's like primary hyperoxaluria, and we have to give do metabolic workup, intestinal disease, pathological skeletal factors, osteoporosis, pathological skeletal factors in osteoporosis, there will be chance of hyperparathyroidism and history of UTI with calculi and presence of gout and informed health and solitary kidney. Solitary kidney, stones in solitary kidney is these patients have only one kidney. So we should not take the risk of a characters developing again and keeping the patients in being, because any stones can damage its renal function. In each episode, this renal function will deteriorate. And renal insufficiency and stones composed of cysteine, uric acid, we have to do metabolic workup. So, and in all children less than 10 years, if you see a stone, you have to do some metabolic workup, because there is a risk of 100% sure that there is some metabolic disturbance underlying this children. What this metabolic workup includes, we have to take blood. So first we will take blood and we will compare see creatinine, sodium, potassium, calcium, uric acid, chloride, phosphate, and blood gas. And after taking blood, you have to take urine samples. That is 2 consecutive 24-hour urine samples. This stored at less than 8 degrees Celsius during collection to prevent the risk of spontaneous crystallizing urine. So blood and urine. In the urine, you will see for pH. So more than 7 pH, 7.5 pH, there is suspicious of infection. And less than 5.8, that he may be having some uric acid stores. And creatinine and calcium oxalate uric acid. So we'll see for if it is having hypercalciuria, that is presence of more calcium in the urine, and hyperoxaluria or oxalates in the urine, and hyperuricosurium, that means uric acid, more uric acid in the urine. And citrates, the citrates will be less in, because it is an inhibitor stone. So in stone formers, this inhibitors citrate will be low. So by checking these urine parameters, we can predict what is the metabolic pathology inside this in this patient. So we have seen that concentrated urine and in more in acidic urine and of lack of this inhibitor citrates, urea is produced in presence of urea is producing bacteria, hypercalciuria, hyperoxaluria, and hyperuricosurium and hypocituria stones are formed. So I am going to discuss only 2 stones, mainly calcium stone. In calcium stones, these are the metabolic abnormality we are seeing. So they will be having more hypercalciuria and hyperoxaluria. So more calcium oxalates in the urine. So calcium is. But you will wonder why hyperuricosuriia happens in this patient. How hyperuricosuriia forms calcium oxalate stones in this patient? Because this uric acid has a specific property that it can act as a nidus or nucleus. So it can start crystallization. So it can act as a nidus, and around this uric acid nidus, more of calcium and oxalate will deposit, and that can accelerate in the formation of calcium oxalate, even if the calcium and oxalate concentration is low. So in patients you see in your OPD with higher amount of uric acid in their blood, they doesn't mean that they will have a uric acid stones. They have more chance of production of producing high calcium oxalate stones. And hypocytruria, because they are inhibitors, they will produce calcium stones. And uric acid stones are found only in acidic urine. And low urine output and hyperuricosuriia are also entities. Cystine stones, renal absorption of cystine in cystinuria. And sewage stone that are infected stones producing alkaline urine by urea producing bacteria. They will convert urea into ammonia, so producing an alkaline pH. So they are associated with sewage stones. These are actually stagnant sewage stones. What dietary advices will you give to these patients? So you can ask them to take an oral intake of minimum 3 liters, so that he can produce a daily urine output of 2.5 liters. So minimum you can advise 3 liters. But in old age, if they take more liters, like 5 liters, 6 liters, they can present with hyponatremia. So 3 liters is obtained, so that 2.5 liters of urine is produced. Water produces mechanical diuresis and alters the supersaturation of stone components. And depending hardness of water, if increase in hardness of water, there will be increased urine and calcium, magnesium citrate levels are excreted, increase directly with urine water. But they had seen that it is a minor concern with respect to stone formation. So can bring hard water also. Coming to the carbonate beverages, you cannot take caffeine. It can increase the risk of stone formation. But carbonated water may confer some protective benefit. So you can drink soda, but not Thompson. Coming to the citrus supplementation, lemon, orange, and grapes are plenty. The grapes also have plenty of citrates, but lemon is the best one because orange, even though they produce urine alkalization, decrease the stone, incidence of stone, they have high sugar content. So high sugar content also, there are more chance of stone formation. And grapes are less desirable because even though they contain more of citrates, but they are rich in oxalates, so it can produce hyperoxaluria and calcium oxalate stones. You should restrict the protein because protein intake increases urine calcium, urine oxalate, and urine calcium excretion. And sodium. This sodium has an high propensity to crystallize calcium, so you should definitely restrict sodium. And obesity. If with increased BMI, larger waist size, weight gain, and these people have an increased risk for stone episodes. And uric acid stone formation in non-obese stone formers may be secondary to the production of more acidic urine in this species. So obese patients will produce more acidic urine, more chance of stones. And impact of weight loss diet. These are weight loss diet. If you take weight loss diet, which are rich in low carbohydrate, high protein diet, this delivers a high acid load to the kidney. So high acid load, more risk of stone. But you can have DASH diet. What is DASH diet? This diet reduces the risk of stone formation. Actually, DASH is dietary approaches to stop hypertension. It includes fruits, veggies, low-fat dairy, beans, nuts. Nuts in decreased quantity. I'll show you this figure. So they can see more of comprises more of grains, fruits, and vegetables, but less of legumes, nuts, fats, and seeds. These are less and low-fat dairy. So there is a misconception that in stones, will you give dietary calcium? Will you take calcium-rich food? Actually, we should not limit dietary calcium because if you limit calcium absorption, calcium intake, there will be increased oxalate in the bowel movement, and it will absorb. If the oxalate is lying free there without calcium to bind, they will rapidly get absorbed into the bowel and go into the blood and produce supersaturation of calcium oxalate because of their excretion in the urine. So you should not limit calcium intake. The vitamin D is slightly safe for stone formers because vitamin D absorbs calcium from the kidney. Low oxalate diet, most of the hyperoxaluria is from the diet. So if you restrict the diet, we can tackle this problem. So what are the hyperoxaluria oxalate rich diet? Especially beetroot, potato, chocolate, black tea, wheat bran, nuts and seeds. These are all spinach. These are all rich in oxalates. So if you calcium oxalates are there, you have to restrict the oxalate rich foods. These are the oxalate rich foods. Vitamin C is, if you take vitamin C, it has more chance of conversion of oxalates. So hyperoxaluria. So more of hyperoxaluria, calcium oxalate pressure. So you have to limit the vitamin C intake also. To summarize, so you will advise the patient, you should take at least 3 liters per day, and you should take a balanced diet rich in vegetables and fibers. The calcium should not be restricted. You have to take a normal calcium amount, that is 4 to 5 grams per day, and you have to limit the salt content 0.8 to 1 gram per kilogram per day advisable, and lifestyle advice, normal BMA and exercise. So these are the tips that you can give to the patients that you see in OPD. This is a complex chart. In this, you have to take history, adequate history. You have to do metabolic evaluation, and if you see hypercalciuria here, you can give drugs thiazides, and you can supplement potassium citrate. Means thiazides are known to decrease potassium and citrate, and so you can address potassium citrate for this patient. And if hypercalcium is there, you should suspect hyperparathyroidism. And uric acid stones, it forms usually in acidic urine. So you can give urine alkalizations like potassium citrate. And if in hyperuricemia due to gout, we can give allopurinol like that. And in infection stones, we have to give antibiotics. Coming to the surgical management of stones. What are the indications of surgical intervention in renal stones? These are indications for surgery in all these patients. If there is stone growth, stones in high-risk patients, that is single kidney in chronic kidney disease, these are high-risk patients. So these stones should be early dealt as soon as possible by surgery. And obstruction caused by stones, infections, symptomatic stones like pain hematuria, according to patient preference, comorbidities, according to social situation of the patient, like if he's a pilot and if he's a traveler, you have to remove his stones. These are the invasive management that we can do for renal stones. This is ESW, extracorporeal shock wave lithotripsy. Previously, we used to do open surgeries, that is cutting open the abdomen and doing stone extraction from kidney, pyrolithotomy, nephrolithotomy, PCNL, percutaneous nephrolithotomy, that I will discuss later, and RARs. For ureteric stones, also open surgeries replaced by lab surgeries, which are replaced by ureteroscopy and lithotripsy. I will discuss later. Vesical calculus or open cystolithotomy, that is cutting open the abdomen by using a fantasy incision and opening the bladder and taking out the stones. Is replaced by cystolithotripsy, so going into the bladder using a cystoscope and crushing it. Coming to extracorporeal shock wave lithotripsy, in this shock waves are generated from a source external to the patient's body are then propagated in the body and focused on the kidney stone. So shock waves are produced outside. This is shock waves are produced here, and we are under CM. The stones are located, and the shock waves are transmitted into the patient abdomen by direct contact. Here we can do it by a local anesthesia, the click gently applying over the abdomen. This is the mechanism of stone combination in the ISW. The main drawback of the stones is this extracorporeal shock wave recursives is that these cannot crush hard stones. So the most common stones that we encounter, that is calcium oxalate monohydrate, which is a hard stone, these are resistant to fragmentation. And these are contraindicated in ESW is contraindicated in pregnancy, uncorrected coagulopathy, antiplatelets, UTI, renal or aortic aneurysms, and patient size. Morbidly obese patient, the shock waves won't travel into the abdomen, into the stone. So obese patients, ESW is not advocated. So this ESW forms a lot of incomplete fragmented pieces. These incomplete pieces can get into the ureter and cause obstruction. Larger or harder the stone, like calcium oxalate, there is high possibility of residual fragments of a significant size. So no, we are not using ESW nowadays. This is the fragmented stones that is collected in the ureter, causing more harm to the patient. It can produce renal trauma and vascular destruction. And if the stone is infected due to the shock waves, this bacteria will escape from the stone into the blood and cause systemic symptoms, sepsis like that. And it can cause trauma to the surroundings in these organs like liver, muscle, duodenum, stomach, colon, liver, spleen, pancreas. So the invasive surgeries include open surgery, PCNL, and RIR. So open surgery has been replaced by PCNL and RIRs. Now, what is PCNL? That is percutaneous nephrolithotomy. Here, the patient is that position prone, and using the CM, we will locate. First, we will specify the collecting system, means the kidney, and we will puncture using the CM. And this puncture will tract, will pass a gate and will dilate the tract, and will put into kidney, and we will extract the stones. So this we have punctured under CM guidelines. So a gateway is passed. So gateway is passed. So we are dilating this tract. So patient dilators. These are metal rods used to direct the tract. The tip of that rod is in kidney, in the desired calyx. So after dilating the tract, we are going to introduce a sheet called FMAS. This black sheet is called the FMAS sheet. So we had introduced a sheet into the kidney where the stones are located. So the dilators are removed. The tract is secured using the gauge, the black gauge. And with the use of this instrument is called nephroscope. So as to see the kidney inside the kidney, nephroscope. So this, so inside the nephroscope, using nephroscope, we can see the kidney and stone. This is a stone. And we can use any energy sources to fragment this. Here we are using a pneumatic lithotripter. It's easy to fragment. It is using the energy of air like a bullet. Stones can be fragmented. And these fragmented stones are removed using a grasper. This is a grasper. We are removing the stone. So all fragments are stone, all fragments are removed in such a way. And finally, we can confirm with the under serum. These are typically calcium oxidation, very hard stones. So in PCNL, we are making a tract like this. This is the amla sheet, and using a nephroscope, we are going inside the kidney and removing those stones. And after that, we remove only this hammers. And we will be able to suture only this skin. We are not able to suture this wound in the kidney. So there are chance of bleeding post-operatively. That is the main drawback of PCNL. So hemorrhage is the most common complication, and it can injure the renal pelvis. It can more fluid absorption from the irrigant we have used during introduction nephroscope. It can injure the pleural cavity by puncture. It can even puncture bowel also, but it is very rare. It can injury to liver, spleen, and sepsis can also have efficacy and infected stones. Coming to tackle the bleeding and all these problems. So a new advance had come, which is called brigade in the renal surgery. In this is we are using a flexible uroscope. It's very thin. We are using this is called Carlson's Flex X2. And we are going, no, we are not creating any tract like PCL. We are going through the urethra. So suppose if it is a left renal stone, we are going through the urethra. We'll go inside this left urinary orifice and go into the kidney. So through the natural orifice, we are going, no wound or anything. So the problem of PCL is that because that we have to let that wound to the wound in the kidney to heal. So the patient is advised for 6 weeks absolute bed rest, and patient cannot be discharged within 1 week. So RIRs tackle all these problems. These are RIRs screenshots. So using that flexible ureteroscope, it's actually inside the kidney. So we are seeing a stone that will constant calcifications. And here in the flexible ureteroscope, that is RIRS, we are using only, we can use only flexible energy sources. We cannot use a rod or anything. So we are forced to use lasers. So initially, homeo lasers came on. This is an homeo laser that we had previously the old surgery. So that we are fragmenting using a laser, homeo laser. So this is a small stone. That's actually big magnified image. The small stone actually is only 8 mm. So the drawback what we have seen in this homeo is that it takes time to fragment. A lot of patients for surgeon is required. So for even 8 mm stone, it will take hours to surgery. So now to tackle this problem, new laser, Tulian laser come. Tulian laser has shown to have higher ablation efficiency than homing, and its area response is 4 times than that of homing. So we can use this Tulian laser for lamp stones. So those stones we are running for PC that we can do RIRs using Tulian lasers, and it produces more stone dust. So stones are made into dust within minutes. This is an RIRS using Thulium. This is an axis sheet. This axis is placed inside the pelvis. So through the axis sheet, this axis is introduced through the urethra, through natural orifice, going to the urethra. Seeing a stone. These are the renal calyxes of left kidney. So now the stone is located in the middle calyx of left kidney. So now we will introduce Thulium laser. So using Thulium laser, it's a matter of minutes. These are called dusting. So stones are made into dust. So within a matter of 10 minutes, we can finish this stone. And after this procedure, we will check all calyxes. I will confirm that no fragments are there, and we will place a stent, DG stent inside the pelvic system so that all fragments can wash out through the stent, and the patient can be discharged the very next day, and no rest is required for this patient. And this stent we usually remove after 2 weeks, sometimes after 1 month. Into URS is actually remove for ureteroscopy for removing ureteric stones. This is a ureteroscope. This is very thin ureteroscope. We will go via the urethra into the bladder, into the ureteric orifice, and into the ureter. So this is inside the ureter. But also we are using thulium laser. The side effect of means the major disadvantage of lasers are that they are very, it can produce any damage, but can even perforate the ureter, perforate any point. You can perforate, means it can cause mucosal damage. But so good experience is required to handle lasers. This is a 15 mm ureter stone. So after that, we also will place a stent, and the patient can be discharged the very next day. But if any pus or anything is there, any chance of infection is there, we won't do surgery in this stone, because if more the time you remain in that system, this this pus can get due to back pressure. This pus can get into the systemic circulation and produce sepsis. So in those cases, we will place a stent and we will deal the stone after 2 weeks when this infection gets settled. So before all this procedure, urine culture and sensitivity is a must. Cystolithotripsy means removing bladder calculus. Using cystoscope, we had found one calculus, and using this is also laser, and we are fragmenting these bladder stones. So should be very careful. It should not touch the bladder mucosa. This is called painting the stone. This is actually foaming laser, so that's why it's taking time. Cystolithotripsy can be done in OP basis. We can do cystolithotripsy on the same day. You can discharge the patient if he passed urine. So these fragments will come through the cystoscope. Thank you. Maximum cycle is can pass after action. But in small yes, there will be eight. 2 million. There is no anymore 4 million. Just as action on the central systems. From the state another thing, where we are unique alpha from the proper. Along with this, we able to useful in that. See, we can give hypertensive along with acute episode, if you give hydrocodone, actually hydrogen, so you will produce more urine. So the question of will increase for more than for example, expression. That's the reason why we are doing close to the extent and curiosity. Even though the acids are not to produce urine. Something maybe some related usually days you can even is supposed to be the reduced or therefore all of them. Doctor, you mentioned about the grades. Parents have a rate that age we be understood, not other one. You mentioned that grades to be understood. Where grades? Other one you can change. Grades means common grades. Other one I don't. Actually, grades are so much. Grades are and grade is the title of peak volume indicator. So it interprets a lot of terms. So actually, that's the reason, maybe that's the reason why we have not advising the use and we next is there are many doctors, including urologists. Then I will not exist. But I will make drugs like stop further connection. Finding my experience has been this is not a but some cases this is not a working but let's say the mechanism systems needs to be working. Don't know the constitution. But we don't this not supposed to stay. We are not supposed to present every purpose. So it's not actually. We are not interested in regulations.